Today we'll be reviewing some language and also the pathology that sort of sparks this discussion on language. This is a review, and if it isn't a review for you, then go back to the original videos and Zoom sessions and have another look at this topic. We'll be talking about arthrosis versus arthritis, tendinosis versus tendonitis, and fasciosis versus fasciitis. So let's start with plantar fasciopathy, the way we started on the session. But you can inject, instead of plantar fasciitis, tendonitis, or arthritis, instead of fasciosis, you can put in tendinosis and arthrosis. The principles are the same for all three, and we'll cover all three. So let's have a look at plantar fasciitis. The clinical characteristics, which you're going to learn later as an essential illness script. For the average case here is a lot of pain. This is severe pain. There's pain with each step, and there's an obligate functional loss of walking. They actually limp. They can't walk normally, they limp. And this is from the first step to the last step, with it getting worse as we go. It worsens with distance. There's exquisite tenderness. With fasciosis, you have to dig your thumb in and try to find a spot. This thing is very superficial. It doesn't take much pressure at all to find it. And the stress test is probably going to be positive with this, where it's generally negative with a tendinosis, unless it's done first thing in the morning sometimes. So that's the diagnostic criteria for it. The causes of this will be systemic or non-systemic. If this is non-systemic, the causes are severe, unfamiliar overuse. Now, this is very severe overuse. This is walking in the wrong shoes over large distances, doing too much. A change in substrate, where you've gone for an office job to working in a warehouse, for example. The same with shoes. You change your shoes and then you overuse it on top of that. And sometimes trauma, you'll get a sudden tearing feeling, more forward though in the anterior foot rather than back on the medial campanile tubercle. And this will be tender in that part of the plantar fascia. Pretty much, unless this is extremely severe trauma, it's likely that there was already some degeneration there. That tear basically tore the remaining healthy fibers. Systemic causes of this, it's rheumatoid arthritis, gout, ankylosing spondylitis, that type of thing. Reactive arthritis do this. Any condition that can give you an enthesitis can give you a fasciitis. And of course, diabetes, always diabetes. For the fasciosis, we'll see, as in fasciitis, we'll see pain distal to the heel pad. So this isn't on the heel, it's distal to the heel pad coming towards the toes. It's over the medial tubercle. The pain is worse after weight bearing, and certainly in the early stages at least, as you continue to weight bear on this, the pain improves. Although it may be more painful at night, depending on how much you do. Tenderness is more difficult to find, and the stress test is probably going to be negative. Now, the causes of this are mechanical, neurological, and neurophysiological. Mechanical is overuse on degeneration. So the overuse is basically the trigger, but there's already degeneration. The pain is nothing like it is from plantar fasciitis. So, and it can also be a change of substrate in shoes, but again, nowhere near the severity of a fasciitis. For neurological, neurophysiological, a collapsed foot, it will stretch out the plantar fascia over time, and basically you'll get a fasciosis degeneration there as well. Slow flow axoplasmic transportation loss. This also goes with fast flow axoplasmic transportation loss, which causes a collapsed foot, but the slow flow actually causes nutritional problems in the end organ of the nerve. So the fascia can become degenerated that way. And again, diabetes can cause this over time. So the main difference between the fasciitis and the fasciosis is the severity of the thing. The main treatment in treatment is you're going to be looking for the causes of fasciosis, whereas the causes should be known to you anyway from the history. There is either severe unfamiliar overuse, which you'll treat by saying don't do that, or changes in substrate of shoes, don't do that neither, or it's a systemic problem which you're going to refer back to your physician for further investigation. Okay, so this slide doesn't talk about the diagnostic characteristics. That'll be on the next slide, but I want to get the idea, because we deal with tendon problems frequently, probably more so than arthritis or fasciopathy. I want to emphasize the causes of this. So tendinopathy consists of peritendinitis, the little sheath around some of the tendon, the lining of the tendon, if you like, and tenosynovitis, inflammation of the tendon sheath and inside it. So you have the lining of the tendon, then you also have sometimes synovial sheaths on the tendon, and then also tendonitis, inflammation of the tendon itself. The first two are not so common with us, and certainly peritendinitis, I really don't know how you differentiate that from a tendonitis. For a tendinosis, this is actually degeneration of the tendon itself. So for the first two, the inflammatory conditions, causes include infections, and it's actually a fairly high cause of tenosynovitis, systemic disease, diabetes, arthritis, anything that again causes sort of that enthesitis or inflammation in collagen tissue, trauma, blunt trauma, direct trauma, and severe unfamiliar overuse. The last one generally causes tendonitis rather than tenosynovitis. Tendonosis, neurophysiological causes or occult mechanical stresses, which we're not going to cover on this course, at least not to any great extent, but these things play a huge role in degenerative processes. Very occasionally, overuse will produce a tendinosis rather than a tendonitis, and likely there is some degeneration in there that's allowed less severe overuse to produce a tendinosis than what you would otherwise expect. Okay, so we're going to use tennis elbow, lateral epicondylitis, if you like. It's a horrible name for it, completely incorrect. But common extensive tendinopathy of the elbow. So above here you can see what the presentation looks like in general for both of these things. There's lateral elbow pain, there's pain on gripping rather than elbow movements, there's tenderness specific to the tendon, and there's pain on isometric wrist extension. Now if we look at tendonitis versus tendinosis, the acuteness of all this is so much amped up on the tendonitis than on the tendinosis. So the presentation here is severe lateral elbow pain, severe pain on gripping. In fact, they may not even be able to grip with any strength at all. There may be obligate functional loss of gripping. There is severe tenderness. You almost just have to run your finger over the top, over the lateral side of the elbow, and it hurts them. There's severe pain and weakness on isometric testing, and on stretching you may well find spasm, but there's certainly going to be severe pain when you stretch this. As I say, there is obligate functional loss usually, and the strap really doesn't help very much. If you put a tennis elbow strap on this thing, it really doesn't help an awful lot. Very, very acute. Causes: medical diseases, infections, direct trauma, and severe unfamiliar overuse. Okay, so for tendonitis, the presentation is much less acute. Moderate lateral elbow pain, pain on gripping, but not obligate functional loss. There is tenderness that you actually have to go in and dig for to find it, as opposed to just running your fingers almost over the top of this thing. There's pain on isometric wrist testing with the elbow straight, and stretching is usually not painful. There's elective functional loss rather than obligate, so they'll say, I don't really want to do it, so I avoid things that's going to hurt me. And there's going to be less aching after, if any aching after the sharp pain. And a strap may help with this. Cause of this is a degenerative condition. So this could be an old tendonitis that is inadequately healed, and it's caused some degeneration in there. If this is blunt trauma, there may be scarring that's actually causing the problem. Muscle weakness will do this as well. So if the extensor muscles are weak, then they basically get overused, even if they're not functionally being overused. This can be the case, and this can be caused by neurological or neurophysiological problems, including segmental facilitation and reflex inhibition. It may be trophic malnutrition from slow flow exoplasmic loss, and the fast flow again will cause weakness in the muscle. Or there may be a chronic friction going on, less so in the elbow because there's not much to friction it. But if you start looking around the shoulder, the so-called impingement syndromes are really just nothing but rubbing. So these are rubbing syndromes rather than impingement syndromes, which makes it sound more sexy than it actually is. So this is how the tendonosis typically exemplifies as a tennis elbow, but essentially all of these look much the same. In principle, only the detail changes. Okay, so differentiating arthritis from arthrosis. As I said, you're much more likely to see arthritis than arthrosis. Arthrosis is an ongoing condition. It may or may not be painful. And in fact, people who talk about joints that click are arthrotic. They're inherently unstable joints to a small degree often that just don't get painful. On the other hand, arthrotic joints can undergo inflammation. Sometimes very minor perturbations can make them swell up and become inflamed. So they turn into arthritis. While a lot of these stay quiescent, the very severe arthrotic joints, so while they do become episodically arthritic, degenerate more and more and get to the point where there's coarse crepitus going on. They've lost range of motion chronically and not because of inflammation, and these are the ones that are often going towards joint replacement. So arthropathy is arthritis versus arthrosis. They can both produce crepitus. Fine crepitus is indication of long-term inflammatory conditions, arthritis, while coarse crepitus, very coarse crepitus, is generally degenerative arthritis, but less coarse crepitus can be either osteoarthrosis or an inflammatory condition. So if you look at arthritis first, there's severe pain, moderate to severe effusion, fluctuant effusion. That can be quite mild or it can be severe. And this is where fluctuant testing, where you're pushing the effusion up and down the joint, is more effective than just feeling for swelling. But you can feel this like flow from one end to the other. If this moves as a mass, so it's sort of a glob, that's probably blood after trauma. It's probably blood, or it may be an infection where the thing has become so thickened, the fluid has become so thickened that you're getting this clumping, this globbing of stuff, and it's never a good sign. There's likely to be warmth. In fact, almost certainly there will be warmth with an inflammatory condition. Depends on how deep the joint is. If you get this in the spinal joints, you're not going to feel warmth. So it depends on the on where the joint is. And the same thing applies with redness. If this joint is deep, then you're unlikely to see redness from it. If it's more superficial, then you may well see redness, which indicates a systemic condition or an infectious problem. Causes in the history, there may be macrotrauma or possibly microtrauma. If it's macrotrauma, then your concern is whether there's an underlying fracture or a ligament tear and so on. If it's microtrauma, it's probably degenerative. That's been triggered to become arthritic. The medial joint line will be turned up with arthritis. As I say, there may or may not be fine crepitus with this. For arthrosis, the pain is mild pain to severe pain, depending on how bad this gets, and how much degeneration is occurring just before replacement. Then that's going to permanently be very severe. But for most of our patients, this will never be a severe pain, and often there is no pain at all, as I said. Rather than effusion, you're going to feel thickening of the joint capsule if it's been there in length of time, providing you can get down to the capsule again, as I say, in the spine. In the neck you might be able to do it, but in the rest of the spine it's very unlikely you will be able to palpate the capsular thickening. There's generally no warmth or redness, but you can get skin discoloration from chronic arthritis. Chronic inflammation can discolor the skin, and it's often a dark, motley look to it, but it's not the redness you would expect to see with systemic arthritis or infectious arthritis. And the pain is often episodic as it flares up and dies down, as microtrauma is applied, or it can be episodic on top of continuous aching. So this is the difference between the two. Okay, no room for my pretty face on this one. I'm sure you're all disappointed. This is the most complicated of the slides, and you can read them at your leisure, but we'll look over the main points. So, looking at arthritis now. We're not looking at arthrosis in this slide. Arthrosis is simply a degenerate joint that may or may not be painful. But arthritis can be caused by infections, so you have a traumatic arthritis. And these are not necessarily foreign invasions like cuts and nicks and that sort of thing. It can be, but often it's more bloodborne than directly traumatic. And the directly traumatic ones are obviously easier. If you see a hot swollen knee and they tell you they've just had an injury to it, then the thought that it's infectious just comes straight to mind. But if it is infectious, it can be very infectious or not very infectious, and you're likely to see the not very infected knee or whatever the joint is. So you'll see progressive pain and swelling. The swelling is going to be larger or smaller depending on how much infection is present. There's no trigger here necessarily, and the onset can take weeks to build up to the point where it becomes really painful and swollen enough for them to go to see somebody. There's often redness, but there may not be. And that redness is a giveaway that it's either a systemic arthropathy or that it's an infection. It's certainly not osteoarthrosis. And there may be a low-grade fever and a feeling of malaise on the patient's part, and there may not be. But you need to take the patient's temperature if you're looking at an arthritis that has no obvious cause. So the differential diagnosis includes gout, reactive arthritis, systemic arthritis, and osteoarthritis itself actually being painful. These joints are pretty degenerative at this time, and these are the ones that are going towards a replacement. But they get differential diagnosis. Always err on the side of it being infection though. But almost any of those, except for the osteoarthritis, require to go back to the physician anyway. You can have a systemic condition, gout, rheumatic type diseases. Ankylosing spondylitis can do this. And again, you have a fair amount of pain here. There may be a dietary trigger or there may be no trigger. Remember again that you may be the first one to see the first joint to become systemically arthritic in this particular patient. So you can't go by the classic textbook identification of systemic arthritis. But it's worthwhile asking about things like tendonitis, fasciitis, and if they've been present in the past. The onset is fairly sudden. It can get worse, but it's actually fairly sudden. And there's going to be significant swelling there. There may or may not be redness again. Not everything will give you redness. Systemic, as far as systemic arthritis, but it generally does. And again, there may or may not be a low-grade fever. So where you get mixed up, gout in particular is often not mistaken for an infection or an infection mistaken for gout. But either one of these two, if that's your leading diagnosis, the physician's leading diagnosis is one of those or both of those, then they will do blood tests to find out which one it is. You don't have that luxury, so you don't really care which one of the two it is. So that's gout basically. For rheumatic conditions, triggerless onset again, plus or minus a general malaise and temperature raises. Other joints may be involved, other tissues, tendons and fascias may be inflamed, and other systems may be involved. There may be colitis, iritis, and so on. This particularly so with reactive arthritis. There is generally morning stiffness with these that lasts more than 30 minutes, usually a lot more than 30 minutes, but not always, certainly not in the early stages. Diabetic arthritis is possibly one of the more common ones you'll see, and this basically is neuropathic in nature, but the sugar also produces degeneration in the joint. So this is a combination probably of Charcot joint, it's sort of a Charcot joint, plus sugar arthritis. But you end up with a fairly significant arthritis there, and it looks like gout or an infection, so it comes on fairly quickly, and essentially these are all much the same thing. This might be microtraumatic. For differential diagnosis, it could be things like adhesive capsulitis and so on. So the differential diagnosis is all pretty much all stay much the same, depending on what joint you're talking about, of course. You wouldn't expect adhesive capsulitis in the knee, for example, although I'm not sure why you wouldn't get it there, but apparently it doesn't. So osteoarthritis is another cause of arthritis. This is the inflamed state of arthrosis. Again, progressive pain. Generally, it's episodic. There's often a microtraumatic trigger for it. You slip, you go to grab something quick, you're picking up too much heavy weight, but there's some trigger for this often. There may or may not be a history of significant trauma. Often there's not, what you would consider significant trauma anyway. There's moderate swelling with these, and if you palpate the joint, you're likely to feel thickening of the capsule, and that's been there for some time. This isn't new. And then, of course, you've got traumatic arthritis with a history of trauma, delayed onset of the severest pain with the swelling. So if you actually fracture something, then you're going to get immediate severe pain. When I say immediate, I mean within an hour or so of the trauma. Whereas with, and that's macrotraumatic arthritis, which is not caused by major healthy tissue disruption, will be delayed. They may feel it at the time it gets hurt, and they will, but the next morning is when it's swollen and more painful. The swelling is moderate compared to some other causes like systemic arthritis or hemarthrosis. Hemarthrosis can be massive, and it won't stop swelling until the joint is so tense that it can't swell anymore, and that is immediate as well. And there'll be a range of motion loss, more flexion loss and extension, but both of them significantly lost. Microtraumatic, there's a history of either minor trauma or no trauma, and often there's a biomechanical dysfunction underlying the inflammation. With the macrotraumatic arthritis, you have to worry about fracture, ligament tearing, muscle tearing, hemarthrosis. So that's it. Now, be careful of things like very severe swelling. You want to be careful of, and refer to the doctor if you believe it's an infectious arthritis or a systemic arthritis that as yet hasn't been diagnosed. I truly do believe that using more rigorous language not only helps in communicating your ideas across and also information across to another person, but it helps you think more clearly. Fasciitis is an inflammatory condition, and it means that you have to use an anti-inflammatory treatment. Fasciosis is a degenerative treatment, and we can rough those up a bit. So if you mix the two up in your head, then sooner or later you're going to treat fasciosis like fasciitis and fasciitis like fasciosis, and you're not going to do the patient a lot of good at all. So try to keep your thinking clearer by keeping your language tight.